Start with the lab diagnosis of Staph aureus infections. Direct smear microscopy, gram-positive cocaine clusters and pus cells. Culture nutrient agar, golden yellow pigmented colonies. Blood agar, colonies with narrow zone of beta hemolysis. Selective media such as mannitol, salt agar, salt milk agar and Ludlam's medium. Culture smear microscopy, gram-positive cocaine clusters. Biochemical identification, catalase test positive, coagulase test slide and tube positive. Protein A detection, identification by automated systems such as Vitek and Maltitov, and antimicrobial susceptibility testing. Now let's see the lab diagnosis in detail. Sample collection depends on the nature of the lesion. Common specimen are pus, wound swab, sputum, mainstream urine and blood. In this figure we can see the direct smear arrow is showing the gram positive cocaine clusters with pus cells, and in figure B we can see the culture smear showing gram positive cocaine clusters. Okay. Now the sample for blood culture, automated blood culture bottles are preferred. For food poisoning, feces, vomiters and toxin contaminated food are collected. For carriers, nasal swabs are recommended. Direct smear microscopy. Gram staining of pus or wound swab reveals pus cells with gram-positive cocaine clusters. However, direct microscopy is of no value when Staph aureus is the part of normal flora in the sample, example, sputum or feces. Cultures. Specimens are inoculated onto various media and incubated overnight at 37 degrees Celsius aerobically. The colony morphology is observed as follows. Nutrient agar. Colonies are 1 to 3 mm in size, circular, smooth, convex, opaque and easily emulsifiable. Most strains produce golden yellow non-diffusible pigments made up of beta carotene. Nutrient agar slope. It produces golden yellow colonies of confluent growth, looks like oil paint appearance. Blood agar. Colonies are similar to that on nutrient agar, in addition surrounded by a narrow zone of beta hemolysis, best observed in sheep blood agar. McConkey agar, small pink colonies are produced due to lactose fermentation. Liquid medium, example peptone water, produces uniform turbidity. Selective media, they are useful when Staphylococcal are expected to be scanty or outnumbered by other bacteria in the sample, example swab from carriers' feces. Salt is added to the media and it is inhibitory to other bacteria but not Staphylococci. Examples include mannitol salt agar, nutrient agar with 7.5% NaCl, others like salt milk agar and Ludlam's medium. Culture smear microscopy, gram staining from the colonies shows gram-positive cocci 1 micrometer arranged in clusters. Hanging drop reveals non-motile cocci. Biochemical test for identification, catalase test. Staphylococci are catalase positive, which differentiate them from streptococci catalase negative. Test to differentiate Staph aureus from CoNS. Staph aureus can be differentiated from CoNS, coagulase negative staphylococci, by various tests such as coagulase test and detection of protein A. Coagulase test. It is the most commonly performed biochemical reaction for identification of Staph aureus. In this figure 51.3a, we see the colonies of Staph aureus on nutrient agar, the golden yellow pigmented colonies, and in B we see the blood agar. The arrow shows narrow zone of beta hemolysis surrounding the colonies. Okay. Now, the tube coagulase test. It detects the free coagulase secreted by Staph aureus. Procedure: colony of Staph aureus is emulsified in the plasma in a test tube and incubated at 37 degrees Celsius for 4 hours. Positive test is indicated by formation of a clot that does not flow when the test tube is tilted. The negative tubes, no clot formation, should be incubated overnight and re-examined, as some strains may produce a delayed clot. This test is different from slide coagulase test, which is mediated by clumping factor. In this figure, we can see the coagulase test A, B and C. A shows the tube coagulase test positive, B shows tube coagulase test negative, and C shows slide showing the coagulase test. Now the slide coagulase test detects clumping factor bound coagulase. Procedure: a colony of Staph aureus is emulsified with a drop of normal saline on a slide to form milky white suspension. Then a loopful of plasma is added and mixed properly. The positive result is indicated by formation of coarse clumps, whereas it remains milky white suspension if the test is negative. Protein A detection. Protein A is present on the cell walls of Staph aureus, which can be detected by latex agglutination test, which differentiates it from CoNS. It is a rapid test. Result can be obtained within 5 minutes. Automation for identification. Automated systems such as Vitek and MALDI-TOF can also be used for rapid, precise identification. Typing of Staph aureus. Typing of Staph aureus to subspecies level is done for epidemiological purpose to trace the source of infection. It is specially useful in outbreaks such as food poisoning affecting a larger community. Typing methods include both phenotypic methods such as bacteriophage typing and antibiogram typing. Genotypic methods such as PCR, RFLP, restricted fragment length polymorphism, ribotyping, PFGE, pulse field gel electrophoresis, and sequence based typing. Bacteriophage typing. Phage typing involves differentiating strains of Staph aureus into subspecies level based on their susceptibility to bacteriophages. Pattern method of phage typing. Phage type 8081 is most commonly associated with outbreaks in hospitals. It is known as epidemic strain of Staph aureus. With the advent of molecular typing methods, phage typing has become obsolete nowadays. Now, the antimicrobial susceptibility test. As Staph aureus develops resistance to antibiotics readily, drugs should be prescribed according to the antimicrobial susceptibility test. It is performed by disk diffusion method on Muller-Hinton agar or by automated MIC detection methods by microbrot dilution, example Vitek. Drug resistance in Staph aureus. Resistance to beta-lactam antibiotics. Staph aureus shows resistance to beta-lactam antibiotics in various ways. Production of beta-lactamase enzyme. Beta-lactamase or penicillinase enzyme cleave the beta-lactam rings, and thereby organisms producing these enzymes develop resistance to beta-lactam antibiotics. This resistance is plasmid coded, can be transferred between Staph aureus strains by transduction. It is produced by more than 90% strains of Staph aureus. The resistance can be overcome by addition of beta-lactamase inhibitors such as cavulinic acid or sublactam. By alteration of penicillin binding protein PBP, it is shown by MRSA strains of Staph aureus. Now the treatment part of Staph aureus. Since Staph aureus rapidly develops drug resistance, antibiotics should be cautiously chosen. Parenteral therapy for serious infections sensitive to penicillin. Drug of choice is penicillin D. Penicillin G. Methicillin sensitive Staph aureus MSSA. Drug of choice is anti-staphylococcal penicillins such as nifacillin and cloxacillin. Note, vancomycin is inferior in terms of efficacy against MSSA when compared to anti-staphylococcal penicillins, hence should not be prescribed for MSSA. Methicillin resistant Staph aureus MRSA. Drug of choice is vancomycin 15 to 20 mg per kg BD. Alternative drugs discussed under MRSA. Empirical therapy. MRSA status not yet known. Vancomycin without an aminoglycoside. Vancomycin is indicated only if MRSA risk is high or condition is serious. Example, a cardiac implant. Oral therapy for skin and soft tissue infections. Sensitive to methicillin, give dicloxacillin and cefaxillin or cefazolin. Okay, resistant to methicillin, MRSA, clindamycin, alternative drugs, cotrimoxazole, doxycycline, linezolid. Okay. Now, methicillin resistant Staphylococcus aureus MRSA. Methicillin resistant Staphylococcus aureus is mediated by a chromosomally coded gene called as MEC-A gene, which alters penicillin binding protein PBP present on the Staph aureus cell membrane to PBP2A. PBP is an essential protein needed for cell wall synthesis of bacteria. Beta-lactam drugs bind and inhibit this protein, thereby inhibiting the cell wall synthesis. The altered PBP2A of MRSA strains has less affinity for beta-lactam antibiotics. Hence, MRSA strains are resistant to all beta-lactam antibiotics. Risk factors. Outbreaks of MRSA occur both in hospital and community settings. Risk factors common to these outbreaks include poor hygiene conditions, close contact, contaminated material, and individuals with damaged skin. Prevalence. MRSA infection rate has been increasing over the last few decades, though it varies from place to place. World MRSA rates are higher, more than 50% in America, some Asian and European countries, and Malta. Countries with lowest MRSA rates are Netherlands and Scandinavia. In India, the MRSA rates vary with year and place. In both 2019 and 2021, it was reported as 42% by ICMR. Types of MRSA. MRSA are either community or hospital associated. Detection of MRSA antimicrobial susceptibility test or using cefoxitin test or oxacillin MIC based method. These antibiotics are used as a surrogate marker for identification of MRSA. PCR detecting MAC-A gene. Latex agglutination test detecting PBP2A. Treatment: vancomycin is the drug of choice for MRSA. Alternative drugs include teicoplanin, linezolid, daptomycin, telavancin, and quinupristin or dalfopristin. Okay. Now the types of MRSA we can see in this table. Community associated MRSA CA-MRSA and hospital associated MRSA HA-MRSA. CMRSA strains express MAC-A gene subtypes 4, 5 and 6, while HMRSA express MAC-A gene subtype 1, 2 and 3. The CMRSA, they are usually more virulent and express several toxins such as pantone ballotine toxin. The HMRSA are multi-drug resistant but the virulence is relatively low. The CMRSA cause invasive skin and soft tissue infections such as necrotizing fasciitis, while the HMRSA cause perioperative wound infections in hospitals and nosocomial outbreaks. Hospital staff are the major carriers. Okay, now the CMRSA and HMRSA terminologies are losing their relevance as many CMRSA strains have been isolated in hospitals also, and the vice versa is also true. Now the treatment, linezolid is useful for skin and soft tissue infection. Okay, the treatment continues. Okay, here. And the daptomycin is indicated for endocarditis and complicated skin infections, not effective for pneumonia. However, even drugs such as tetracycline, erythromycin, or cotrimoxazole may also be effective in non-life-threatening infections. Antimicrobial susceptibility testing is necessary before an alternative drug is used. All beta-lactam drugs should be avoided. However, fifth generation cephalosporins such as ceftobiprole, ceftaroline, and ceftolozane have shown some activity against MRSA. Resistant to vancomycin, VRSA, and VISA. Erroneous and overuse of vancomycin has led to the emergence of resistance to vancomycin. It may be of low-grade resistance known as VISA vancomycin intermediate Staph aureus or high-grade resistance known as VRSA vancomycin resistant Staph aureus. The MIC minimum inhibitory concentration of vancomycin to VISA and VRSA isolates are 4 to 8 and more than 16 microgram per ml respectively. The current guidelines have recommended considerations of alternative drugs if vancomycin MIC is more than 1 microgram per ml, as treatment failure has been frequently observed beyond this MIC level. VRSA is very rare in India. It is reported from few places such as Hyderabad, Kolkata, Lucknow. However, VISA is more common, frequently reported than VRSA. Mechanism of VRSA is mediated by VAN-A gene, whereas VISA is due to increase in cell wall thickness of Staph aureus. The VAN-A gene is believed to be acquired from vancomycin resistant strain of Enterococcus facialis by horizontal conjugal transfer. Fitness cost. Acquisition of a VAN gene is often associated with compensatory mutations in the genes responsible for survival, which results in reduced fitness of Staph aureus. In contrast, fitness cost phenomena is not commonly observed in MRSA. This explains why PRSA is seen very rarely, less than 0.1%, whereas MRSA prevalence is so common, 30 to 40%. Treatment of VRSA should be based on antimicrobial susceptibility report. Linezolid, telavancin, daptomycin, and quinupristin, dalfopristin are the effective drugs. Now the control measures. Prevention of spread of Staph aureus infection in hospitals involves screening of MRSA carriers among hospital staff should be done when there is an outbreak. Mannitol oxacillin agar is preferred medium for this purpose. Treatment of carriers is done by using topical 2% mupusin for nasal carriers and chlorhexidine body bath for skin carriers. Stoppage of antibiotic misuse in hospitals ensure proper infection control measures such as hand hygiene, most efficient way to prevent hospital spread, isolation of patient and all other measures of contact precautions. Coagulase negative staphylococcal infections. Most of the coagulase negative staphylococcal infection are harmless. They are the harmless commensals and less virulent than Staph aureus. However, recently their role as pathogen is increasingly being reported. Staphylococcus epidermidis is the most common CoNS, 75 to 80% isolated from clinical samples. It is present as normal flora on the skin, oropharynx, and vagina. However, its pathogenic role is greatly enhanced in the presence of prosthetic devices. Pathogenesis. Staph epidermidis involves two-step process. Initial adhesion to the prosthetic device. The surface adhesions of the organisms bind to the host serum or tissue constituents such as fibrinogen or fibrinolactin coated on the implanted prosthetic surface. Colonization. Staph epidermidis can produce the extracellular polysaccharide material glycocalyx or slime that facilitates formation of a protective biofilm on the device surfaces. Biofilm appears to act as a barrier protecting bacteria from host defense mechanisms as well as from antibiotics. Manifestation. Staph epidermidis is the most common cause of prosthetic device related infections such as endocarditis with insertion of valvular prosthesis and ventricular shunt infections. It is also a common cause of stitch abscess. It is coagulase negative but positive for phosphatase test. Staphylococcus saprophyticus is the urinary tract infection UTI in sexually active young women. Staphylococcus lugdunensis and Staphylococcus schleieriferi. Recently, these organisms have been associated with more serious infections such as native valve endocarditis and osteomyelitis. The enhanced pathogenesis may be due to the expression of virulence factors such as clumping factor, therefore exhibit positive slide coagulase test and lipase, which are usually absent in other cons. Okay, so this completes our chapter. Let us now see the expected questions. First question, write an essay on the 55-year-old male was admitted to hospital with complaint of severe pain in the lateral aspect of left calf and small amount of pus discharged from ingrown hair. On physical examination, the local area was red, warm, tender. Pus was aspirated and subjected to gram stain, showing gram-positive cocaine clusters. Cultured on the blood agar, showing golden yellow pigmented beta hemolytic colonies. So clearly, this is a case of Staph aureus abscess. Okay, the organism and the infections caused virulence factor and the lab diagnosis we can write. Okay, we can write the short notes on toxic shock syndrome, MRSA. Okay, so this is all we can do. Now, MCQ scalded skin syndrome is mediated by epidermolytic toxin. All of the above can be given for the treatment of MRSA except mepropenem. We have not read it in this chapter, so this cannot be given. Which of the following is the least preferred antimicrobial for the treatment of methicillin sensitive Staph aureus? It's vancomycin. Synergioaminotropic toxin includes what? It includes gamma hemolysin and pantone valentine toxin. Staph aureus is differentiated from CoNS by all except it's the catalase test, which is sugar fermentation test differentiates Staph aureus from CoNS. It's the mannitol test. Okay, now all the following beta lactam drugs can be given for the treatment of MRSA except ceftriaxone, ceftobiprolol, and ceftolazone can be given. So, this piperacillin and tazobactam cannot be given. Now, about MRSA, all are true except in India. MRSA prevalence in hospitals 30-40% is correct. MRSA rates are higher in India than America. It's wrong. Mediated by MEC genes correct. Havoxetin risk is superior to oxacillin for detection. It's correct. So the correct answer is the incorrect one is MRSA rates are higher in India than in America. Now about VRSA, all are true except VRSA is mediated due to Van gene. It's correct. Visa is due to increased cell wall thickening. It's correct. VRSA is most common than Visa. It's wrong. Visa is more common than VRSA and the fitness cost phenomena is seen in VRSA. It's correct. Now the 10th, community-based MRSA differs from HA-MRSA in all except the strains express MEC-A subtype 456, right? Express more pantone valentine toxin, right? They cause more invasive skin and soft tissue infection, correct? Multidrug resistance, it's wrong. Now, Staphylococcus epidermidis, all are true except accounts for 75% of cause. It's correct. Phosphatase negative is wrong. It's phosphatase positive. Produces a biofilm and causes stage abscesses. Okay, so this completes our chapter, the staphylococcal infections. Next, we'll be starting with beta hemolytic streptococcal infection in the next video. Okay, for the time being, like, share, subscribe. Thanks for watching.